1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
When we think about the human body performing at its absolute peak, our minds usually jump straight to elite athletics.
Right.
You know, you picture a marathon runner hitting the pavement, or like a gymnast suspended in midair. We are conditioned to associate peak physiological performance with intense, visible, muscular exertion.
We look for the sweat, we look for the heavy breathing, and the obvious physical output to tell us that a body is, well, working hard.
Exactly. But one of the most complex, demanding, and highly choreographed physical marathons a human body can endure is happening completely out of sight.
Oh, absolutely.
We are talking about a system that operates on a hidden chemical language, a system capable of literally building an entirely new vascular network and a temporary organ from scratch.
And it profoundly affects the daily lives, the energy levels, and the medical realities of half the global population.
Yeah, today on the Deep Dive, we are opening up a comprehensive clinical guide on female reproductive health. And look, we're not going to give you some 8th grade biology lesson or, point out where the fallopian tubes are.
You know the basic geography.
Right. We are exploring the hidden chemical conversations, the intense physiological marathons of pregnancy, and the lifelong evolution of this reproductive system.
It is a biological masterpiece. And yet, even for those of us who live with this operating system every day, the actual mechanics of it are often shrouded in clinical mystery.
Or at the very least, wrapped up in centuries of cultural misunderstandings. So whether you are actively family planning, curious about the invisible background processes of your own body, or just want to be better informed, we're extracting the most fascinating need-to-know insights.
To really understand the timeline of the system, we have to look under the hood at the baseline machinery.
Okay, where do we start?
Well, the best place to start is by clearing out some of the oldest myths attached to the external anatomy. The guide actually tackles this head-on by specifically addressing the hymen.
Oh, wow, yeah. Historically, there's been so much cultural and even legal weight placed on this specific anatomical structure, right? Like it's some sort of definitive indicator of a person's sexual history.
Exactly. But the clinical reality is entirely different. The hymen is merely a remnant of fetal development.
Wait, really? Just a remnant?
Yeah. It is a thin piece of mucosal tissue that forms while the fetus is developing in utero, and it serves absolutely no reproductive purpose.
So it doesn't seal anything off?
Yeah. It doesn't function as a biological tamper-evident seal, and its appearance naturally changes with age, physical activity, and fluctuating hormone levels, period.
I mean, if we strip away the cultural baggage and look purely at the science, the physical structures, the uterus, the ovaries, the cervix, they're really just the hardware of the reproductive system.
Right, the hardware. But the software running the entire operation is chemical. The core dynamic of the monthly menstrual cycle is this intricate push and pull between two specific hormones.
Estrogen and progesterone.
You got it.
Let's break down the mechanics of that push and pull. How do these two actually govern the cycle?
So think of the menstrual cycle in two distinct phases, separated by the release of an egg. In the first half, which we call the follicular phase, estrogen is the absolute dominant force.
Okay.
Estrogen is the architect. It signals the body to develop female sex characteristics, and it orchestrates the initial buildup of the uterine lining. It basically creates the environment.
But then, once ovulation occurs and that egg is released, the environment shifts.
Completely. We enter the luteal phase, and progesterone steps into the spotlight. If estrogen is the architect, progesterone is the sustainer.
Sustainer.
Its specific job is to take that uterine lining, thicken it up, fill it with nutrients, and stabilize it to prepare for a potential pregnancy.
And if no pregnancy occurs?
The progesterone levels eventually crash. That sudden drop is what signals the uterus to shed the lining, and the cycle starts over with menstruation.
So what changes in that chemical conversation when an egg actually is fertilized? The guide details this incredible cascade of events, right?
Mhm.
The zygote forms, travels down the fallopian tubes, and implants in the thickened lining of the uterus.
Right. And at that point, the outer layer of this early embryo, a structure called the trophoblast, which eventually becomes the placenta, starts manufacturing a hormone called HCG.
Human chorionic gonadotropin.
Exactly. And that chemical signal is the pivot point for the entire physiological timeline.
Because without it, the ovaries would just naturally stop producing progesterone a couple of weeks after ovulation.
Yes, and the uterine lining would shed, taking the implanted embryo with it.
I picture HCG as this emergency, high-priority, do not delete chemical email. It gets blasted from the newly implanted embryo straight to the ovaries, basically shouting, "Hey, we have a situation down here. Keep the progesterone coming."
I'd actually push that analogy further. It's less like an email and more like a hostile takeover of the factory floor.
A hostile takeover.
Yeah. HCG violently overrides the standard monthly cycle to protect the new environment. It forces the system to stay in the luteal phase indefinitely.
Oh.
And the production of HCG ramps up incredibly fast, doubling every couple of days until it peaks around 10 weeks into the pregnancy.
If you are listening to this and you've ever dealt with these hormonal shifts, you might be wondering how much this isolated reproductive software actually affects the rest of the body.
Oh, it's huge.
Because if estrogen, progesterone, and HCG are constantly fluctuating, surging, dropping, I mean, it can't just be localized to the pelvis.
It is entirely a whole body issue. These hormones cross the blood-brain barrier. They actively alter neurochemistry, which influences sleep architecture, baseline mood, energy levels, libido.
So the reproductive system doesn't exist in a vacuum.
Not at all. Maintaining hormonal balance is fundamentally tied to day-to-day neurological and physical well-being.
So if the body is running this highly automated, delicate hormonal factory designed to constantly prep for a pregnancy, what happens when we actually want to intentionally build one?
Well, the clinical data reveals a pretty sobering reality, which is that nearly half of all pregnancies are unplanned.
Wait, half?
Nearly half, yes.
Which means the body is often building the foundation before the person even realizes construction has started.
That is precisely why general baseline health is prioritized for anyone of reproductive age, regardless of their current family planning intentions. But if someone is actively trying to conceive, the clinical guidelines recommend starting preconception preparation a full 3 months prior to trying.
And the absolute non-negotiable during that 3-month lead time is folic acid. The guide recommends 400 to 800 micrograms daily. Let's explain why that specific nutrient is so heavily prioritized over everything else.
Folic acid is essential for the proper formation of the neural tube.
Which eventually becomes the baby's brain and spinal cord, right?
Exactly. Without enough folic acid, the neural tube might not close completely, leading to severe structural birth defects like spina bifida. The catch is that the neural tube forms and closes within the first 28 days of pregnancy.
Which is before most people even miss a period or take a pregnancy test.
Right. By the time you know you were pregnant, that critical window for spinal development has already closed. So having folic acid saturated in your system beforehand is a massive preventative safeguard.
Here is where the guide really caught my attention, and I want to unpack the mechanism behind it. The text specifically warns against taking common over-the-counter medications when you are trying to conceive.
Right.
We are talking about NSAIDs like ibuprofen, basic aspirin, and pseudoephedrine, which is just standard decongestant cold medicine. Why are common, everyday painkillers suddenly treated like contraband?
It all comes back to the hidden marathon we discussed earlier. When a body is preparing for or entering pregnancy, it isn't just growing a fetus. It is building a massive new circulatory system and an entirely new organ, the placenta, to filter and deliver blood.
So it's essentially a massive plumbing project.
A highly sensitive plumbing project, yeah. Medications like NSAIDs and aspirin actively alter how blood clots. Pseudoephedrine is a vasoconstrictor. It works by shrinking blood vessels to clear your sinuses.
Oh, wow.
You do not want to introduce chemicals that restrict blood vessels or interfere with clotting pathways when your body is desperately trying to increase blood volume and lay down millions of microscopic new vascular networks.
That makes perfect sense. You're basically disrupting the supply chains. So assuming the foundation is laid, the pregnancy progresses into the trimesters. The first trimester is famous for high fatigue and nausea.
Very famous.
But clinically, it's also the most precarious window.
The first 12 weeks are a period of intense, rapid cellular differentiation. Organs are forming from scratch.
Right.
Because of this complex construction, it is the window with the highest risk for spontaneous abortion, what we commonly call miscarriage, and the highest risk for congenital anomalies taking shape.
As the pregnancy moves into the second trimester, the nausea usually fades, which is a physical relief. But the clinical tracking shifts. This is when quickening happens, right?
Yeah, quickening. That's the first time the pregnant person can actually feel fetal movement, usually between 16 and 20 weeks. And week 20 is a major diagnostic milestone.
What happens at 20 weeks?
You have the complete anatomical ultrasound to ensure all those organs formed correctly in the first trimester. It is also the point where providers start measuring fundal height in centimeters.
Let's explain the fundal height measurement, because it sounds a bit archaic. The doctor literally takes a soft tape measure and measures the pregnant belly from the pubic bone to the top of the uterus.
It seems low-tech, but the mechanism is brilliantly simple. Between 20 and 36 weeks, the measurement in centimeters should roughly match the weeks of gestation.
So if you are 25 weeks pregnant, your fundal height should be around 25 centimeters.
Exactly. It is a highly effective, non-invasive way to track that fetal growth is staying on a standard curve without requiring a weekly ultrasound.
Which brings us to the third trimester, the home stretch. The surveillance ramps up heavily here. Appointments go from monthly to weekly.
Yes, and there's a checklist of very specific medical interventions.
Like the swab for Group B strep between 36 and 38 weeks.
Right, to ensure the birth canal is free of bacteria that could harm the baby. The pregnant person receives a Tdap vaccine, and then there's the RhoGAM shot for Rh isoimmunization.
Let's demystify that jargon. What is RhoGAM actually doing?
Every person has a blood type, and it's either positive or negative. That's the Rh factor. If a pregnant person has a negative blood type, say O negative, but the fetus inherits a positive blood type from the other parent, we have a biological conflict.
Okay.
If any of the baby's positive blood mixes with the mother's negative blood during the pregnancy or delivery, the mother's immune system will view those positive blood cells as a foreign invader.
It essentially mounts an allergic reaction to the baby's blood.
It creates antibodies to attack and destroy those red blood cells. The RhoGAM shot acts like a temporary cloaking device. It stops the pregnant person's immune system from recognizing the positive blood cells, preventing it from creating those dangerous antibodies.
With all these complex interventions to track, the guide offers a surprisingly simple mathematical formula for figuring out the ultimate question.
When is this baby actually due?
Exactly. It's called Nagel's rule.
The calculation works by accounting for a standard 28-day cycle with ovulation occurring on day 14 and an average human gestation of 280 days. You take the first day of the person's last menstrual period, subtract 3 months, and then add 7 days.
So, if the last period started on July 1st, you jump back 3 months to April 1st, add 7 days, and your estimated due date is April 8th. It's a quick, mechanical way to set the clock.
It provides the baseline estimated date of delivery.
Now, to support this sheer amount of physical construction, building the placenta, doubling the blood volume, growing the fetus, the body's input requirements undergo a radical shift.
Oh, absolutely.
People always throw around the phrase eating for two, which conjures up this image of needing to consume double the food.
The caloric reality is much more modest. The maternal client only needs an additional 300 to 500 calories a day to fuel this process.
So not a second dinner.
No, that is the equivalent of a bowl of oatmeal with a handful of nuts, or a sandwich.
The calories are modest, but the hydration requirement is enormous. The guide specifies a minimum of 64 ounces of water a day.
Minimum, yes.
And the mechanism there is that the body is literally manufacturing amniotic fluid and drastically increasing the maternal blood volume. You need raw materials, water, to create that fluid.
And while we are on the topic of fluids, we have to look at the strict limitations placed on caffeine. The clinical guideline is to keep caffeine consumption under 200 milligrams a day, which is roughly one standard 12-ounce cup of coffee.
I was trying to visualize why the threshold is so rigid. I think of it like kinking the garden hose that supplies the entire operation.
That is the exact physiological mechanism. Caffeine is a powerful vasoconstrictor. It tightens and narrows blood vessels.
So if you consume too much, you are literally shrinking the vascular hose that delivers oxygen and nutrients through the placenta to the fetus.
And prolonged vasoconstriction means chronic underdelivery of those nutrients, which research shows can actively inhibit fetal growth and lead to lower birth weights. Keeping caffeine under 200 milligrams ensures that vascular hose remains wide open.
The guide also emphasizes that this entire process carries different risks depending on the demographic profile of the patient. For instance, advanced maternal age, which is the clinical term for being over 35, brings a higher risk for conditions like gestational diabetes and high blood pressure.
The vascular system ages just like the rest of the body. Arteries naturally become a bit stiffer, which means the cardiovascular stress test of pregnancy is harder on a 38-year-old body than a 24-year-old body.
The guide also dives into an area of reproductive care that is frequently misunderstood, which is navigating pregnancy and fertility for transgender men.
This is a crucial point.
A transgender man may be taking testosterone as gender-affirming therapy, which alters secondary sex characteristics and usually suppresses menstruation. The assumption a lot of people make is that if you don't have a period and you are taking high doses of testosterone, you have a built-in form of birth control.
The clinical texts are unequivocal about this. Testosterone is not a contraceptive. Even if menstruation is entirely suppressed, the underlying ovarian machinery is still intact. A trans man with a uterus can absolutely still ovulate and achieve a pregnancy while on testosterone therapy.
Which means the biological potential for that hidden marathon is still working there, completely functional.
It requires proactive clinical discussions. Fertility preservation, such as egg freezing, needs to be addressed before initiating hormone therapy if biological children are desired in the future. And conversely, if pregnancy is not the goal, active contraception must still be utilized.
This brings up a fascinating point. If the human reproductive system is so remarkably resilient that it can initiate a pregnancy even while navigating testosterone therapy, how do we effectively pull the emergency brake?
Right.
Let's look at how contraception actually interrupts this timeline.
Contraception requires intercepting either the chemical software or the physical hardware of the system. Natural family planning, for instance, attempts to bypass interventions entirely by intensely tracking the physiological signs of ovulation.
So if you are charting this at home, you are acting as a detective for your own basal body temperature and cervical mucus. The guide points out that right before ovulation, the basal body temperature actually drops slightly, averaging 96 to 98 degrees.
Yes.
But right after the egg is released, the body temperature spikes to 97 to 99 degrees.
And that temperature spike is driven directly by the release of progesterone. The body is literally heating up the incubator. Simultaneously, you track the cervical mucus. Under the influence of estrogen, right before ovulation, the mucus transforms from cloudy and sticky to abundant, clear, and stretchy, often compared to raw egg whites.
The mechanism there is that the estrogen is thinning out the mucus to create a hospitable, fluid highway for sperm to travel through. This is a fascinating method, but it demands an incredible amount of daily discipline.
Exactly.
Moving to barrier methods, condoms are the physical blockade. The guide underscores that condoms remain the only contraceptive method that simultaneously prevents pregnancy and protects against sexually transmitted infections.
Everything else we are discussing only addresses the pregnancy variable. When we look at hormonal interventions, we are chemically tricking the body. The combined pill utilizes both synthetic estrogen and progesterone, while the mini pill relies solely on progesterone.
But the combined pill comes with a major flashing red contraindication in the clinical guide. If a patient is over 35 and smokes or has a history of hypertension, the combined pill is considered dangerous.
It all comes back to the vascular system. Synthetic estrogen increases the blood's natural tendency to clot.
Right.
When you combine that chemically increased clotting factor with age, which naturally hardens the arteries, and smoking, which damages the endothelial lining of the blood vessels, you create a deadly synergy.
It's sobering to think that a routine daily pill, when mixed with something as common as aging or smoking, can turn into a major cardiovascular hazard.
Oh, absolutely.
You are essentially creating the perfect storm for a thromboembolism, a dangerous blood clot that can break off and cause a stroke or heart attack.
The risks of hormonal manipulation are real, which is why clinical oversight is necessary. On the far other end of the spectrum, the guide addresses coitus interruptus, or the pull-out method. It is notoriously unreliable, yet remains highly prevalent.
The failure rate is massive. But if we look at the mechanics of why it fails, it's not just about timing, it's about the biology of the sperm. The guide notes that sperm can survive inside the female reproductive tract for up to 3 days.
That 72-hour window is the fatal flaw of the method. You can perfectly execute the pull-out method on a Tuesday, but if sperm were introduced on Sunday and the patient ovulates on Monday, the chemical cascade has already begun.
Wow.
It only takes one microscopic cell surviving in the hospitable cervical mucus to initiate the entire process.
And when contraception does fail, the guide directly addresses the standard of care for abortion counseling. We're looking at this purely through the lens of the clinical text, which outlines the ethical mandate for healthcare providers.
The clinical standard dictates that when a patient seeks counseling for an unplanned or unwanted pregnancy, the healthcare provider is required to offer accurate, scientifically sound information about all available options.
Regardless of how state laws vary, the baseline standard of care is rooted in patient autonomy. The provider must respect the client's personal and cultural beliefs, and they are ethically bound to keep their own personal biases out of the medical conversation.
Providing objective, comprehensive care without judgment is the cornerstone of the profession.
Family planning, pregnancy, the monthly hormonal roller coaster, this represents a massive portion of the human lifespan. But the timeline doesn't end there.
No, it doesn't.
Eventually, the ovaries dial back their production of estrogen and progesterone. The factory floor begins to shut down, moving us into a completely different era of bodily maintenance.
The end of the reproductive years demands a shift in preventative care. As the hormonal protection of estrogen fades, the risks for certain cancers and bone density issues change.
I noticed a significant update in the guide regarding preventative screening. For a long time, the annual pelvic exam was a dreaded mandatory yearly ritual.
Oh, yes.
But the guidelines have shifted. Annual pelvic exams are no longer universally required if the patient is asymptomatic.
The medical community has moved toward targeted, evidence-based screening rather than routine physical probing just for the sake of it.
So if we're throwing out the annual pelvic exam for asymptomatic people, how do doctors actually catch things like cervical cancer in time? What replaces that baseline?
We rely on the Pap test, which specifically scrapes cells from the cervix to look for abnormalities. If you are between 21 and 29, the guideline is every 3 years. If you are between 30 and 65, you can safely extend that to every 5 years, provided the Pap smear is combined with an HPV test.
Because cervical cancer is almost entirely driven by the human papillomavirus. If the provider tests for the virus itself and the result is negative, they know the biological risk of dangerous cellular changes occurring over the next 5 years is incredibly low.
Exactly right. It's a more intelligent way to screen. Alongside that, mammograms to screen for breast cancer are recommended to begin at age 40.
That covers the clinical screening, but the physical transition itself, menopause, is a massive physiological event. The guide defines perimenopause as the transitional lead-up, which can start up to 3 years before the final menstrual cycle.
Natural menopause occurs at an average age of 51. But from a clinical diagnosis standpoint, a person isn't officially in menopause until they have experienced 12 full consecutive months of amenorrhea.
A full year with no period, it's a long runway. And during that runway, the drop in estrogen wreaks havoc on the body's temperature regulation. The guide contains a statistic that really frustrated me.
Which one?
It states that 80% of individuals experience hot flashes during perimenopause, but only 20% to 30% actually seek medical attention for them.
That massive gap between the number of people suffering and the number of people seeking treatment highlights a deep flaw in how society views women's pain and the aging process.
We've normalized the suffering. If you are listening to this and approaching this timeline, remember, just because a symptom is a natural part of aging does not mean you are required to white-knuckle your way through it unassisted.
Definitely not.
There are hormone replacement therapies and non-hormonal medications available. There are management strategies.
The goal of clinical care is to preserve quality of life at every single stage of the timeline.
We have mapped out an incredible physiological journey today. We started with the monthly hidden orchestration of estrogen and progesterone. We unpacked the complex plumbing and the 64-ounce water requirements of building a pregnancy, navigated the vascular risks of the contraceptive control panel, and looked at how targeted screening replaces the outdated annual exams as the system transitions into menopause.
The sheer complexity of the system is awe-inspiring. But the most important takeaway for anyone navigating this timeline is the necessity of self-advocacy. You are the only person experiencing the nuances of your body. Whether you are asking for a detailed medication review to protect an early pregnancy or demanding symptom management for hot flashes that are ruining your sleep, you have to advocate for your quality of life in the clinical setting.
I want to leave you with a final provocative thought from the source text to mull over. We talked a lot about the unpredictability of this timeline today. Well, the guide mentions a specific blood test called the anti-Müllerian hormone test, or AMH.
It's an incredible piece of diagnostic technology.
The text notes that AMH levels can provide a window into the remaining number of eggs in a person's ovaries, and it strongly correlates with the time they will naturally hit menopause. Imagine the shift in personal autonomy, career planning, and relationship dynamics if everyone had routine access to a simple blood test that could accurately predict their personal biological clock countdown. It's a glimpse into a future where the hidden marathon of the human body isn't just a mystery we endure, but a highly understood system we can actually plan around.